Good morning. I have the pleasure of introducing today Dr. Spencer. He is a professor of neurology here at OHSU. He is also the director of the Epilepsy and Clinical Neurophysiology Fellowship Program, and is the director of the OHSU Comprehensive Epilepsy Program. Dr. Spencer did his undergraduate training at Harvard University and earned his MD at the University of Minnesota. After graduating, he completed both his haven't had enough coffee yet today, neurological residency and fellowship in clinical neurophysiology and epilepsy at Stanford University. He has been involved in many areas of neurology and epilepsy education, including serving as editor of Neurology and on the Professional Advisory Board of Neurology Now. He has served on educational committees for the American Epilepsy Society and is a member of the AES and a fellow of the AAN. Dr. Spencer's research interests include neuroimaging, electrical stimulation as treatment of epilepsy, and neurological education. He maintains an active epilepsy practice and is interested in both medical and surgical management of epilepsy. Please welcome Dr. Spencer.
Great, thank you, Matt, and I'm still working on getting enough coffee myself. That was a very nice introduction, and Paul also. And welcome, everyone. This is really nice to see such a good turnout here and see some familiar faces and probably some familiar faces online that I can't see, so welcome to all the online participants as well. So my task this morning is to talk about some of the new things. We're going to start out with the new. And I'm going to talk I'll try to start by kind of putting some of this new information into context, and as we go, I'll not just jump into talking about new things, but try to talk about where these new treatments may fit into the existing therapies that we already have. And specifically, I'm going to be talking about some new medications that have recently become approved, a new medical device that's now available, and then finally talking about some new kind of rescue medications or medications for seizures that can be used in more emergency or urgent situations. These are things that might be used for people that are having frequent seizures that are clustering, or even potentially for people that are having prolonged seizures to try to avoid getting into a more emergency situation. So at the risk of stating the obvious, this is the first talk of the day. I just want to make sure we're all on the same page when we start talking about epilepsy. So the simplest definition of epilepsy is just a condition in a person who's had more than one unprovoked seizure. So I just want to make sure when we think about, a young child who's had a high fever and had a convulsion, that might be considered a provoked seizure, and that person really doesn't have epilepsy. Same thing with somebody who has diabetes, for example, and they take too much of their diabetes medication, their blood sugar goes too low, they have a seizure. That's considered a provoked seizure. And so after somebody has had usually a single, either provoked or unprovoked seizure, most often we're observing them, trying to understand why it happened, but not necessarily starting therapy. But once they've crossed that threshold to having two unprovoked seizures, they've met the definition of epilepsy. In most cases, treatment is being initiated at that point. And with initial therapy is usually with anti-epileptic medications, usually starting with a single medication rather than combinations of medicines. And just the general overall experience is that with the first medication that's tried to treat seizures, about half of people will become seizure-free. In other words, the first medication will work well. They don't need to go on to try other things, and generally things are in pretty good shape at that point. After 2 or 3 medication trials, we see the proportion is about this kind of pale green section here. So about 2/3 of people with initial attempts at therapy with 2 or 3 medications by themselves or sometimes in combination will become seizure-free. But that leaves a lot of people, with epilepsy being such a common condition, who don't get good seizure control, who don't have complete seizure control with initial medication treatments. And so this group here, who are not seizure-free with initial therapy, are the group really where the talk today is going to pertain to most. They're going to be the group and the people who are most interested in new medications that might be available new medical devices, and who might be candidates who might have a need for rescue therapy if they're having clustering or repeating seizures. So again, specifically, I'm going to talk about several new medications that were recently approved in the last couple of years. A new medical device called the NeuroPace RNS device that can be used for difficult to control seizures, and then this idea of rescue medicines for clustering or repetitive seizures. This shows just a graph looking at a list of different anti-epileptic medications and then time along this direction. And you can see there's really been an accelerating pace of development of new medications. You also see that this cuts off at the year 2000. I didn't have a pretty picture for more current things, but if you look at all the new medications developed just in the last 10 or 15 years, it goes way off the chart here. And so a lot's been happening. There are a lot of new things. And it's good, I think, to take the opportunity this morning to talk about some of these new things and just get up to date on all the new stuff that's been happening. In the last couple years, these are the most recently approved medications. There's some extended release forms of some familiar medications that have been around for 10 or 15 years. These include extended release forms of topiramate or Topamax and oxcarbazepine or trileptal. And so these are sort of updated versions of familiar medications. They offer some advantages, often once daily dosing, potentially better side effect profiles. But because they're not dramatically different from the older medications, I'm not going to focus on talking about those as much, but we'll spend some more time talking about two relatively new medications, one called perampanel or Fycompa, and another called eslicarbazepine or Aptiom. And so before kind of jumping in and talking about all the nitty-gritty about the details of these medications, I wanted to introduce a couple of patients. These are Jake and Natasha, and I'm going to use their stories to illustrate how we might think about applying these new medications or new therapies. How do they fit in the context of a patient's actual story? So does anybody actually recognize Jake or Natasha? Hopefully not, because they're not actually real people. These are computer-generated images, and they got internet users to vote on what they thought were attractive facial features. So you have a couple of more attractive people than me to look at while I'm talking here. And even though these are fictitious characters, I'm going to use them to illustrate sort of a real-world issues that people experience. So we'll first talk about how their epilepsy began. I'm going to start with talking about Jake. So Jake was 17 when he had his first seizure. He was up a little later than usual studying, but really nothing else was out of the ordinary for him. And he had a witnessed generalized tonic-clonic or grand mal seizure. His second seizure occurred the next year when really nothing at all was happening. He was at home, just relaxed, watching TV, had a second very similar seizure. And at that point, had a diagnosis of epilepsy and was started on therapy. Natasha was younger. She was 12 when she had her first seizure, and her seizure type was actually different too. It began with some twitching or jerking in her left face, which then spread to her left arm and leg, and had some confusion or alteration of consciousness with it as well. She had a second seizure that was very similar just a few weeks later, had the diagnosis of epilepsy and went on therapy as well. She initially did pretty well with therapy, but by about age 18, her seizures became more frequent and were more difficult to control at that point. So they both had some testing. I'm not going to dwell on a lot of this, but I'll just show you they both had EEG or brainwave tests. And in Jake's case, he had a normal-looking EEG, which did not mean everything was fine. It just means that during that 20 or 30 minutes where the brainwave activity was recorded, we didn't see any abnormalities that explained why he had seizures or where they were coming from. And Natasha, on the other hand, had an abnormal EEG. This was between her seizures. This was not a seizure, but she had these electrical abnormalities here we call spikes, and these were located in the right central region. So on the right side, we thought probably near the areas that are important for controlling motor function on the left side of the body. That was the general location where we saw them. They both also had pictures of the brain, in this case an MRI, which is the most detailed pictures of the brain we can get, looking for a seizure focus. And in Jake's case, again, he had a normal MRI, so it doesn't mean that everything was fine and that he didn't have seizures. It just meant that we couldn't identify a focus where the seizures were coming from. And Natasha, on first look, actually had a pretty normal-looking MRI, but as we looked closer, we could see, if you follow the cortex, or kind of the ribbon of the wrinkled surface of the brain here, you can see in one spot, it's a little thicker looking. There's more of this gray signal, and so she actually had a pretty subtle developmental abnormality of the brain. This is something that happened as her brain was developing, but she just didn't develop seizures until she was age 12. The left side of the screen here is actually the right side of her brain, so this is in the right central area, pretty much the same place where we saw those spikes on the EEG. So what happened next with people? So Jake started on medication after his second seizure. He's now tried 4 different medications. He's not seizure-free, but he's done a lot better as the medications different ones have been tried and the doses have been adjusted. He now is mostly seizure-free for extended periods of time, but about every 6 or 12 months, he'll have a breakthrough seizure. And if he has a seizure, it's usually a big convulsion, a grand mal seizure, and then it'll be followed by a series of smaller seizures about every 10 or 15 minutes. And that can go on for a period of hours sometimes. So he has this kind of clustering pattern of seizures when he has a breakthrough event. Natasha also started on medication after her second seizure. Her first medication, she developed a rash, and as many of you know, side effects can be very common with medications. She tried a second medication, still continued to have seizures, several per month, and a third medication was added to the second, helped a little bit, but not dramatically. And by now, she's tried 6 different medications. She's still far from being seizure-free. She has several seizures per month, and she's unable to drive and has a lot of the limitations that go along with having fairly frequent uncontrolled seizures. So I'm going to branch off here. I'm going to leave Jake aside for a moment, and we're going to focus on Natasha here. And so the question is, what should Natasha do next? She's been through quite a few medication trials, not getting to where she wants to be with being seizure-free. And so I would suggest this is actually a good point where she should connect with an epilepsy program. A level 4 program is one that has kind of the highest level of resources for addressing all the different needs of somebody who has difficult to control seizures. This website is for the National Association of Epilepsy Centers, and anybody around the country can log into this and find, where are epilepsy centers near where they live. Level 4 centers in this region include the OHSU program here. Seattle, Sacramento, and San Francisco all have level 4 programs. There are also other excellent epilepsy centers that are not level 4 here in Portland and also in other parts of the region. So why should she do this? Well, one thought is to try to avoid this endless cycle of either cycling through different medications and not really making any progress, or maybe even worse, we see certainly people who have been on just one medication. Their physician adjusts the doses up and down a little bit, but really the message is kind of accept the status quo. You're going to have seizures, and there's not a lot to do, which is really not the right message to send. And in a more comprehensive epilepsy center, work can be done to make sure we have the right diagnosis. We know exactly that we're dealing with epilepsy and what type of seizures and what type of epilepsy is going on. There'll be people that are experienced with medication management, both the older and the newer medications. Sometimes access to new investigational medications that aren't available to the general public become available. And also, very importantly, just access to non-medication options. So these are things like epilepsy surgery, if somebody's not responding well to initial medication trials, or devices, which I'll talk about a little bit. Currently, it's the vagus nerve stimulator and the NeuroPace RNS device that I'm going to talk about today. So, I don't think we would say that magic happens at these epilepsy centers, but it's an opportunity to look at things in depth and really think about all the different options that are available. Okay, come on in. So for Natasha, she actually underwent an evaluation for epilepsy surgery. This could be a whole nother talk and probably should be at another one of these symposia in and of itself, but the focus was on trying to see if we could tell exactly where her seizures were coming from and whether that spot was safe to remove surgically to stop the seizures. And so she underwent a range of different tests to try to reach those goals. And what happened at the end of that is that we saw that, she did have a focus seen on her MRI scan, this right frontal cortical dysplasia. Both her between seizure EEG showed spiking in that area, and we actually reported seizures that showed that they were coming from that area. And her epilepsy surgery team decided that, these seizures were very well localized, but it was really right on top of areas that are important for controlling the motor function of the left side of the body. So the conclusion was that it would not be safe to remove that focus, even though we knew exactly where it was. If it was in a different location, then surgery actually would have been the preferred treatment because it could have been curative. But in this case, the risk of doing the surgery outweighed the benefit of removing the seizure focus. So she and her team went back to kind of considering the other options. And so there's a whole range of different things that could be considered. Today I'm going to talk about some new options that could be available to her in the form of new medications, and then this new device called the NeuroPace RNS. So in terms of new medications, I'm going to focus on two that were recently approved. This first one, called eslicarbazepine, or Aptiom, was just recently approved last fall. I believe it's not available in the pharmacies, but it's expected to be released kind of any day now. And its approval is for adults at this point, and is add-on therapy for people with focal or partial onset seizures. So these are seizures that begin in a particular part of the brain, could be any spot, it doesn't really matter where, and then spread to varying degrees to cause the symptoms of the seizures. So that's the group that the medication is designed to treat. The way that it works, or the mechanism of action, is very familiar because it's very similar to some of our older medications, and I called it son of oxcarbazepine. Oxcarbazepine is triluptol, and grandson of carbamazepine, or Tegretol, because they're very closely related to triluptol. It's almost sort of a purified version of the active component of triluptol, and then more distantly related, maybe it's a second cousin, I don't know, to Tegretol, some relationship. And so all of these drugs work by acting on a part of the brain cells or neurons that fire too rapidly during seizures. In this case, it's the sodium channel located on those cells. And even though the mechanism is very similar here, the thought is that this new form, this new version of it, may have some advantages over the older versions. And some of these potential advantages, one is it's fairly long-acting, so it can be once a day, and anybody who's had to take twice a day, or especially 3 times a day medication, or 4 times, knows that this is a nice thing. You can take it once a day. It may be more selective for blocking sodium channels that are rapidly firing during seizures. So these sodium channels opening and closing are a part of normal brain function. So we would obviously want something that's selective for stopping the rapid firing that happens during seizures, but something that will leave the normal functioning of the sodium channels and the brain cells unaffected for normal function. So it looks like this may more selectively target abnormal seizure activity and leave alone a little bit better normal brain activity. There's no, the grandfather, Tegretol, has a breakdown product or a metabolite called the epoxide form that can cause a lot of the side effects. And so this has an advantage that it doesn't have this epoxide breakdown form. Again, another reason it may be less likely to produce side effects or be complicated to manage. And then finally, it has minimal processing by the liver, and it's mostly cleared by the kidneys. So that's an advantage as well. This is the one slide I'm going to show just about the effectiveness of this drug, and this is kind of combined information from the 3 big studies that led to its approval. And I'll just try to explain here. It shows the responder rate, and this is a term that's used a lot when describing how well drugs work. What they mean by responder rate is that whether or not a person's seizures have been reduced by 50% or more. So if you knock the seizures down by half or better, that person is considered to be a responder to that medication. So the more responders we have, the higher the bar is, the better that medication is doing for controlling seizures for more people. So here's the response for a placebo, even a sugar pill in the short term of a study. About 20% will respond to that. The lowest amount of the drug didn't look much different than the placebo, but then you can see as we got to the medium and then the higher dose, more and more people became responders to that medication. Not a lot of people became seizure-free in this study. These were medication that was studied in people with very difficult to control seizures, but you can see nearly 40% had their seizures cut in half or better, which is pretty good. Side effects are generally mild to moderate and are very similar to ones that we're seeing in the relatives in Tegretol or Triloptol. And these include dizziness, coordination problems, sleepiness, nausea, vomiting, double or blurred vision. And these are, in general, dose-related. If the dose gets too high for that person, these are the kinds of things you might expect to see. They can be helped or eliminated by reducing the dose or adjusting doses. Mood issues are something we always want to track with starting any new medication. It does not seem to be a particular problem with this medication, but just something we always want to keep an eye on. And then, like its relatives, Triloptol and Tegretol, low sodium can be a problem. Probably less of an issue than those older ones. It's another potential advantage, but we need to periodically check blood tests just to make sure that blood sodium does not go too low, because rarely that can cause problems. Okay, so in general, this is probably an incremental improvement on some of our previous medications. Not a game changer, but has a lot of nice features that may be an advantage and another nice option to have for people. The other new medication that was recently approved, this actually was approved at the end of 2012, but has just recently become available and is available in the pharmacies now, is Perampanel, or they all have two names. The brand name is called Fycompa. And this was approved, again, for adjunctive or add-on therapy for people with partial or focal onset seizures. Age 12 and older is the official approval for it. And this is a very different medication. It has a very different mechanism of action than things we've had access to before. And specifically, it blocks a type of glutamate receptor. Now, there are all these different chemicals in the brain that are chemical messengers that send signals back and forth. And glutamate is the main one that when it's released, it causes brain cells to become more excited or fire more often. And so since there's, in general, in the brain, too much excitation during seizures, it would be a very attractive mechanism to be able to block some of that excitation to try to help control seizures. And that's the specific mechanism that was designed and is in play with this new medication. For some of you who are maybe more visual people, I just made a few little cartoons. And, again, in epilepsy, there's the challenge that there's an imbalance between having too much excitation or too little inhibition, too much too little of the slowing down of firing of brain cells. And so when this balance tips is when a seizure happens. Either too much excitation, too little inhibition, or both can tip the balance and tip somebody into having a seizure. So many of our medications work on this end of the balance over here by trying to increase inhibition and kind of quiet down the overactive brain cells and bring things back into balance by boosting the inhibition. This new medication works in a way that not as many medications work by trying to limit the excitation directly at this glutamate receptor, directly at the site where excitation happens. So trying to minimize excess excitation to bring things back into balance that way. So as I said, this is approved for treatment of partial onset seizures, people over age 12. It's quickly and completely absorbed and is fairly long-acting also. So it also has the advantage of once-daily dosing, which again is a really nice feature and really is a brand new mechanism, something we don't have any of our old medications. None of them use this way to try to treat seizures. So it's kind of exciting in that way that it generates some new ways to treat seizures. This is kind of a busy slide. This is my one slide showing the effectiveness, and I'll just show you. Here is when people entered the study, when they went on the medication, if their seizures got better, the bar would be higher here. So this is the kind of the amount that seizures were reduced during the treatment trial. And if we look at all people with all different types of seizures here, each of the colored bars represents a different dose of this new medication. So starting from low dose to high dose. And this is the placebo or sugar pill. So you can see as we went to higher doses, there were more people who responded, more seizure reduction happened. And if we look specifically at one seizure type, these are secondarily generalized seizures. So these are the people that have spread to cause grand mal or convulsive seizures. Those people seem to respond especially well to this medication, or that seizure type seemed to respond. So the most severe seizures had the best response to this new medication. The flip side of this, again, thinking about side effects. Again, most of them were mild to moderate in severity. A lot of these are very familiar to people who have taken seizure medications before. The dizziness, sleepiness, and headache were the top three most common ones. Again, very dose-related, so it's possible to modify these or eliminate them by just doing some dose adjustments. This one does have what's called a black box warning, so there's particular attention being drawn to the possibility of having behavioral or psychiatric side effects with this. Now, it was rare. Only 12 people in all the trials of this medication had problems like this, which is about 1% or 1 out of 100 people. But they could be very serious, and so this black box was put in, which says that there could be serious or life-threatening behavioral reactions. Most of these were things like aggression and hostility. And so the recommendation is to monitor people for changes in mood or any of these kind of personality or behavior changes with it, and obviously then reduce or even stop the medication if those are moderate or severe. So it's an exciting new medication. It has a very different mechanism. It's relatively easy to use with the once-a-day dosing. But like all new medications, we need to be very cautious and monitor people when they start on new medications because of some of the common side effects or these more rare but potentially serious side effects. Okay, now I'm going to completely switch gears away from medications and talk about a new medical device. This just became approved at the end of 2013, and it's called the NeuroPace RNS neurostimulator. And here is a picture of the device, and it gives you a sense of the size here with somebody holding it in their hand. Somebody said it's about the size of an iPod Shuffle, but I think it's maybe a little bit bigger than that. And so the device has a small computer in it and a battery to run it, and then it's connected to two leads that go to the seizure focus. So a surgeon will place this in or on the seizure focus, or can actually be used to treat two separate places where seizures are coming from in the brain. And this shows just kind of a diagram of what it might look like in place. So it's placed in the place of a piece of the skull, so it lies flat against the head. There's no bump sticking out or nothing visible once it's surgically implanted. And then these leads, you can see, are going to, in this case, two different seizure places where seizures begin in the brain for this person. So the device is continually monitoring brain activity through these leads, and when the beginning of a seizure is detected, it will use the same leads to deliver a brief electrical stimulation, basically to kind of shock the brain back into a rhythm and stop the seizure from happening before it causes any symptoms. When I say shocked, I mean a small electrical stimulation that the person would not be able to feel. But the idea is to constantly be monitoring for seizures. When it's detected, give an electrical stimulation very quickly to head it off before it starts. And here's just an EEG, a brainwave diagram of what this looks like when it works. These are the recordings from some of these leads, and this shows the seizure beginning here. The device detects it and then gives a brief electrical stimulation. This is usually about 1/10 of a second. And then you can see that developing seizure has just been stopped in its tracks, and you don't see any ongoing seizure activity after that stimulation was delivered. That's the theory, and that's how it should work when it's effective. So this has been approved as of last fall, winter. It's approved for use in adults with partial onset seizures and people who don't have seizures controlled, just despite treatment with two medications. Most of the people who had this device in the trials had tried many more medications than that, often 8 or 10. They may have tried other forms of therapy, and they generally had frequent and pretty disabling seizures to go to this stage of having, an implanted device to treat seizures. So once the device is in, when you come to a clinic visit, your physician can use this laptop and just a little plastic device called a wand that's laid on top of the device, just on the, against the head, to program it. So we want to program the device to be better and better at recognizing the start of a seizure, and then to use the right therapy in response to that to stop the seizure before it gets going. The person who has the device in also has a similar arrangement at home. They have a laptop and a little wand, and every day they can just place the wand up against the head, download all the information from the device, send it to a secure web-based site, and then we can log in and take a look at what's happened with seizure activity in the last 24 hours, or over the last month, or over the last year, however long it's been in. So in addition to being a really interesting new form of therapy, this has also opened up a whole window into what's going on with seizures and with people's brainwave activity every day, day after day at home in a way that we've not had access to being able to see before. And we have 6 people here at OHSU who've been involved in this trial and have had the device in for, I think 6 years is the longest so far. I'm going to show a couple of slides trying to explain what this looked like in the studies and how effective it was. Bear with me, they're a little bit complicated, but the way that the study was done was that there were 191 people in the main study. Everybody had the device implanted, and then everybody was allowed to recover for a month just without starting any therapy. At that point, half the people had the device turned on right away, and half the people had a delay in starting the therapy or the device until 5 months after implant. So we had kind of a half group who were getting active stimulation, half group who were sort of the control group temporarily, but then everybody got stimulation on after that. So this is the point where stimulation was started in the blue group. This is half the patients, and down is better. So you can see from their usual seizure frequency, as the stimulation went on, the seizure counts dropped, whereas in the people who did not have stimulation on, they wandered back up to where the baseline was. For some reason we don't understand, in the first month everybody got a little bit better after the surgery implant, and that's kind of an unexplained finding. But that was temporary in the people who did not have ongoing therapy. They bounced back to where they were before. The therapy group continued to get better, and if we follow these out, these are by months, eventually the lines met. In other words, the people who had therapy started later did improve, and improved just as much as the people who had therapy on from the beginning. And if we looked way out, so this is now looking at months, this is going out as far as 5 years, the arrangement is a little bit different here. Higher is better. So these are the percent of people who either were responders, had their seizures cut in half or better, or just looking at how much their seizures were reduced. And it seemed like over time, things continued to get better and better, so that by the end of 5 years, the majority of people had more than a 50% reduction in their seizures. And I think the actual figure was about 5 or 6% of people in the study who had incredibly difficult to control seizures were seizure-free for more than 6 months. So it was not a miracle cure. It did not replace the need for medications for these patients, but a lot of people did much better from having very difficult to control seizures, and a number did become seizure-free for some extended periods of time. To get into the study, people had to have at least 3 seizures per month pretty consistently, and so that is a big change from that frequency down to being seizure-free for those people. And because, just to make the point that seizure counts are not the be-all, end-all, we really care about quality of life for people and how are people doing overall. So this looked at people who had the device in and functioning for 2 years. How was their quality of life compared to the time before they got the device in? And this is called the QALY. This is a measure, it's a survey that's used a lot to look at quality of life in people with epilepsy. And it has a whole bunch of different measures, but you can see most of these to the right is better than before they had the device. So most things in terms of different aspects of quality of life were better in people after having the device for 2 years than it was before the the device was put in. So coming back to Natasha's story, so this story is not, we don't have an ending to the story. She is considering RNS therapy, this NeuroPace device, because she, in some ways, could be an ideal candidate. We know exactly where the seizures are coming from, but it's not in a place where it's safe to remove and be cured surgically. So we could, this offers an opportunity to direct very specific therapy to that seizure focus without causing harm or causing weakness on the opposite side of the body. She's also interested somewhat in perampanel just because it's a very new mechanism of action and it's different than all the other medications that she's tried previously. I'm going to come back to Jake in the last couple of minutes here. So Jake is not seizure-free, in a little bit better situation than Natasha in that he'll go much longer periods of time without seizures. And he's continuing to consider different options to try to get over that threshold of being seizure-free. But in the meantime, he also wanted to talk about what's available for rescue medications, because when he has a breakthrough seizure, again, he has this clustering pattern. And what can we do if he has a first seizure to interrupt that so he doesn't have to come to the emergency room and get emergency therapy for these clusters? So the term cluster seizure is often used. There's a whole bunch of other words you might or might not have heard. Sometimes they're called acute repetitive seizures, serial seizures, repetitive seizures, or crescendo seizures. And there's no real official definition for this, but what we're talking about is people that have, when they have a seizure, they may have repeated multiple seizures, so it's usually 3 or more seizures after that first one over a relatively short period of time, so less than 24 hours. And often these are within minutes or hours of each other. And this can happen with any seizure type. It's relatively uncommon. Only about 3% of people with epilepsy have these cluster seizures, but if any of you have them or know someone who does, it's a big deal, and so it's a very important issue to tackle for those people, with one big goal of just trying to avoid getting into more emergency situations and even the need to go into the emergency department and get emergency care. Anything we could do to prevent that would be a big step forward. So what's available right now mainly is a form of Valium or diazepam that's given by rectal administration. So these are preloaded soft tip syringes that have to be given by rectal route of administration. It's been pretty widely adopted in kids because it's just practically easier to do, and in adults it's been more difficult, both even at home just because people are bigger, and of course out in public and in social situations this can present all kinds of difficulties. The other alternative is mostly giving things by mouth, and while that's you think would be a good way to do it, the main limitations here are you give something by mouth and it's much slower to be absorbed. So somebody who's having frequent cluster seizures, you really want something that's going to get in and act quickly. And also there's some potential safety concerns. If somebody's not quite awake after their first seizure, there's more risk of aspirating. They may not completely absorb or swallow the medication. And so the backup has always been, calling 911, getting the paramedics, getting emergency department care. And, while that's a critical link in making sure that people are safe, nobody likes going to that step if they don't have to. So having other options would be great. As I said, this rectal gel administration is not as widely adopted in adults. And there was actually a poll a few years back looking at why this was. You might all think that it's obvious, but they asked people who were eligible for this form of therapy, is it embarrassing to get medication that way? You think everybody would say yes, but actually the split was about 50-50 for people out in public. Some were equally kind of embarrassed to have their seizures, unfortunately, in public, as they were to get medications by this route. And when you actually directly asked people, is this embarrassing to get medication in this form, 2/3 of them actually felt no. And I think this was being driven by was a strong preference to not have to get dragged into the emergency room and have an ambulance ride to the hospital and go through that whole thing. People are tired of that once it's happened once, and almost anything different than that is more attractive. So while a lot of people, I think, found this acceptable, maybe more than you would think, I think there's lots of room for better options and things that would be easier to use and more just socially acceptable in public. And so what's out there, what's on the near horizon, none of these are currently approved therapies, but are quite far along in the pipeline. So medications you could give by intranasal, given a nasal spray to give something that would be absorbed quickly, or something that could be like given as a quick injection into the muscle where it could be absorbed rapidly as well. These are both being actively pursued and likely to see products in both of these realms very soon. So intranasal administration, this just shows how you can aerosolize something. You can have preloaded nasal sprays where it's just a quick 1 second spray up the nose, can be given in between seizures, can be given safely when somebody's in the middle of a seizure as well, for the most part. And this graph shows, this is just one example using intranasal diazepam or Valium. And if we look at the red line here, this was the Diastat or the diazepam rectal gel. And if we look over time, when somebody's given that medication, it gets absorbed very rapidly to a peak, and then it gradually goes away over time. And so for comparison, the same dose of diazepam was given by a nasal spray, and that's the green line here. And you can see it's virtually identical. It gets absorbed very, very rapidly, and then kind of goes away about at the same rate. So in the controlled laboratory setting, at least, the levels get there very quickly, and there are a bunch of studies going in now with this and similar medications to see in people who are having seizures, does it work as well, or how well does it work? And pretty far along the path to hopefully being an approved therapy that you could just carry in your bag or purse and have ready if a seizure happened, to avoid clustering seizures. So an exciting option. We actually have a study going on here at OHSU for people who have cluster seizures, where they could get access to this medication even before it's approved and contribute to the study of the drug. I just listed our study coordinator's phone number and email here. If any of you have cluster seizures or family members or friends, this study is still open for probably several months. And feel free to contact us if you just have questions about it or know anybody who might be interested in participating. The other approach that's been studied quite a bit is intramuscular injection. And so a lot of people are familiar with this drug called an EpiPen. So this is people that have allergies to bee stings and other things where they can get into trouble very quickly with an allergic reaction. They can carry this EpiPen around, and then if they have an allergic reaction, just put it over a muscle, push a button, and it triggers a quick auto-injection to get the medication in very quickly. So the same technology has been adopted for use for acute seizure treatments. And in the past, there have been some concerns that maybe giving medications this way, they don't get absorbed quite as rapidly with the seizure medications. But with some new formulations now, we see curves that look very similar to this, absorbed very rapidly and completely. And so there have been a couple of big studies, one looking at emergency treatment outside of the hospital for people that have prolonged seizures. And both the effectiveness and the safety profile looked excellent in that study. And so this is something that's, again, moving along in the pipeline. There's no EpiPen for seizures available right now, but something we'll probably be hearing more about very soon. So with Jake, he's continuing to look at options to get to that goal of achieving complete seizure control, but he's looking forward also to some of these new therapies coming out so that if he does have a breakthrough seizure, he can nip it in the bud so he doesn't have this clustering of seizures happening for hours afterwards. I'm going to pretty much wrap up there. I hope that I've given you a chance to think about some of these new therapies that are out there, but still keeping in mind the goal is to achieve seizure freedom. If you're not there, or you know people who aren't, getting a more detailed evaluation to consider all the different options is definitely worthwhile doing. And I want to just leave you with a message that, this is sort of the tip of the iceberg, what I presented here. It's a very, very active time for development of new medications and new therapies. And that really means hope for a lot of people who don't have seizures completely controlled right now. So thank you very much for your attention.